Hello, thank you so much for having me today. So I'm just going to talk about some of the main points that distinguish pediatric and young adult melanoma from adult melanoma. Just to, for a frame of reference, I'm a pediatric oncologist by training. As pediatric oncologists, we often see patients up to the young adult age, and I would say about 25 would be the cutoff where pediatric oncologists would be taking care of a patient. So there's some overlap with the adolescents, young adults, and then the younger kids, prepubertal. So we'll just review a little bit of the incidence, risk factors, and related conditions specifically related to pediatric melanoma, how we classify these lesions, how the kids present often, and some prognostic features in diagnosis and treatment. We won't spend too much time on that. So the first question I always get whenever I tell anyone that I'm a pediatric oncologist that sees melanoma is, do children actually get melanoma? And the answer is yes. So statistics, while melanoma is not the most common skin cancer in adults, it's definitely the most common skin cancer in children. There's about 400 new cases per year in the U.S. for children diagnosed under the age of 20. When you get into the older age population, so our 15 to 19-year-olds, it's about 4% of the cancers diagnosed. And just looking back as we progress through the numbers, in about 2 decades, there were about 2,000 patients in that 15 to 19 age bracket diagnosed. Almost all of these will be cutaneous melanoma. And then as we get a little bit older, so in the 15 to 29-year-olds, it becomes the second most common cancer. And then as comparison in the older young adult population, third most common in women and second in men. So to put this into a frame of reference, so about 96,000 new cases of melanoma per year in the U.S., only 400 cases of melanoma are in children. And so this is less than 1% of the total cases of melanoma, which is why it's often not recognized. And also for a frame of reference, there's 15,000 cases of childhood cancer overall. That's every single cancer diagnosis that we see per year. So you can see, even just comparing this to melanoma, which is only one cancer in adults, very rare. So a drop in the bucket, but important nonetheless. So about a decade ago, this started becoming more recognized in the pediatric oncology setting. There was a report out in General Pediatrics, main journal of pediatrics, where they were reporting that childhood melanoma was becoming an increasing health problem in the U.S. And this really brought it to the forefront of many people's thoughts, and it coincided somewhat with when a lot of the advances were being made in melanoma, and I think, we started to think how we were going to extrapolate all of these advances in the adults into the pediatric setting. So like I said, there was an increased incidence from the 70s up into the mid-90s, but actually, if we dig into the data, it looks like the incidence is decreasing somewhat over the last 2 10-year periods, and we don't really know what that's due to yet. We think that perhaps some of the sun protective health programs that were initiated in the 90s we're starting to see the effects of those, so there's less indoor tanning. I see far less of my patients that go to indoor tanning beds as compared to probably a decade ago. And there's certainly increased parental awareness. So while melanoma is usually not what parents are thinking of every day when their kids go outside, I would say parents are very, very good about sun protective measures for their kids. When I see a child with melanoma and I ask the parents if they've ever had a blistering sunburn, they say, no, never. I would never let my kid get a sunburn like that. So, we're doing a good job in that sense, but certainly still seeing cases. So some risk factors that are somewhat unique. So we can see babies with melanoma where the tumors passed from the mother to the infant through the placenta. There's a few other rare conditions. So babies that are born with giant congenital nevi have a higher incidence of having melanoma later in their life. There's a few immune conditions that predispose you to a diagnosis of melanoma, and then really weakened immune system. So within our practice in pediatric oncology, we often will see patients who have had bone marrow transplants for other cancers come back in with a skin cancer later in their life, but still within their childhood frame. And there's another unique association babies who had a cancer of the eye called retinoblastoma have a certain gene mutation that puts them at increased risk for melanoma as well. And the other risk factors that we know of are the same in pediatrics as in adults. So the fair skin, light colored eyes, red and blonde hair, kids that don't tan well, how often they're exposed to sunlight, how many common or benign moles they have, whether or not they have a history of an abnormal mole or dysplastic nevi, and whether or not there's a history of melanoma in the family. So one of the questions that is often asked, especially when I have a new patient with melanoma who's young, is this genetic? Are my other kids at risk for melanoma? And to answer that question briefly, I would say we don't know for sure, but there are some instances where it's more prevalent. So there was one study, we looked at 60 families that were termed melanoma-prone families, and those were where there were 3 family members, at least 2 of those being first-degree relatives that had melanoma. And when we looked within those families, there was a 6 to 20-fold increase in kids within those families being diagnosed with melanoma as well. Half of these patients will have a common mutation, CDKN2A, and the other genetic changes are either unknown or just less prevalent and not well characterized yet. So certainly if we're seeing a new child with melanoma and they tell us that 5 other family members have had melanoma, we're going to be extra vigilant with the other children. So just a little bit of terminology because it's different. And I know sometimes I'll talk to my adult colleagues here whenever they get a young adult with a more pediatric cancer. It's just a little bit different. So there's melanoma, and that's easy. We know that term. And then there's a lot of other terms that become very confusing. So we have atypical melanocytic tumors and atypical tumors of uncertain malignant potential, or MELTUMs. Atypical nevus, atypical Spitz tumor, atypical Spitzoid neoplasm. And this is when it gets really difficult, when a kid has a biopsy, and this from a dermatologist who's not expecting to have a melanoma come back in a kid, and they see these terms, it's difficult to know where to go, and that's when we ask that those patients be referred to us. Most of them won't be a melanoma, but we'll get into a little bit more detail why this is important. And there's more terms. So the way that I like to think about it is that there's melanoma in 3 flavors in kids. There's conventional melanoma, which I'll explain is, for all intents and purposes, looks the same as adult melanoma. A big category that we see is something called Spitzoid melanoma that I'll talk about in the next slide. And then there's melanoma arising within these congenital nevi that children are born with. So a little bit on Spitzoid melanoma. This is Sophie Spitz. She was an American pathologist back in the 40s. She was noticing a series of patients that were children who had lesions removed that for all intents and purposes under the microscope looked like melanoma, but the kids were doing better. They weren't having the same outcomes or the same poor outcomes that the adults were, but the lesions weren't all benign. So every now and again there would be a kid that had metastatic disease and died due to their disease. And they got these lesions took on her name, and so lives on to call these melanomas Spitzoid melanoma. And I should mention this is where some of the confusion comes in, because there's some nevi that are completely benign. They're not going to metastasize, and we just call those Spitz nevus. Then there's the gray zone of atypical Spitz tumor, and then there's clear-cut Spitzoid melanoma, and distinguishing between these can be very difficult. Also, a few decades ago would do sentinel node biopsies, a decade ago, we would do sentinel node biopsies in all of these kids, and we were noticing that they very often, almost 30% of the time, would have a positive sentinel node, but then they wouldn't go on to have the same outcomes as older patients with melanoma that had a positive sentinel node. And so the significance of that is really unknown, and we can't always guide the family that if we have the information with a sentinel node, that it's going to be helpful or potentially harmful. So the challenges, the challenge of this is the challenge of treating a rare disease. The management's really derived from adult data as we try to generate some of our own data, but still there's so many more patients diagnosed that are adults, and so we have to extrapolate some of that information to our young children. But also there's delays in diagnosis. There's a low index of suspicion. They present atypically, which we'll talk about next. And then, like I said, it's very difficult to identify an atypical nevus from a cutaneous melanoma, and that's when we get these reports of atypical spitzoid tumor. So a little bit about the low index of suspicion. So these are the ABCDEs of melanoma. Many people have seen these slides. We teach these to families if a lesion is asymmetric, if the borders are uneven, if the color is variated, if the diameter is larger than about an eraser and a pencil, or if it's changing, if it's an ugly duckling, if it's evolving. Those are concerning signs or symptoms. But, we see kids like this, but in pediatric melanoma, it really is not the same ABCDEs. So one study looked at a cohort of kids and found that in the 0 to 10 age group, most of them did not present with these conventional criteria. More of them did in the older population, so the kids that are post-puberty, but still a significant portion of them don't present with that black mole that so many people recognize. So there had been this new ABCD criteria that we see with the kids with melanoma. So often they're amelanotic, meaning that it's a red nodule, it's a pink flesh-colored bump on the skin. It's not black, it's not brown. It really does. The B is for bump. It's often looks smooth, just like you're seeing in this picture. If they can bleed, they're often uniform color. And then there's really no specific size criteria. And what families will often tell us is that it wasn't there. They can't remember whenever they saw it, but they knew it wasn't normal and it just popped out of nowhere. And a little bit about the difficulty that I've been alluding to. So we need a biopsy for diagnosis, and everybody does know that. When we get one of the gray zone lesions, there are molecular features that can help us in classifying the lesion as either truly malignant or not. But I would really like to emphasize that there's really no one molecular marker that's been identified to date to predict those kids that will have an inferior outcome. So I won't go into all of the details of these, but we've been after this holy grail now for years, trying to find if there's one marker where if we have one of these kids, we're not sure if it's a melanoma, and we get the test back and it has this molecular change, can we say for sure that that lesion is dangerous? And the answer is no, we really cannot. We certainly have some molecular tests that we know are associated with a more aggressive behavior within the lesions, and can be associated with those patients who have either died from their disease or have had metastatic disease. But we also know that there's other patients that have a poor outcome and didn't have those molecular features as well. So we do a lot of this testing and a significant amount of counseling with families whenever we get these results back regarding the implications of them. And with this, I just want to emphasize that children are not little adults. This is our favorite saying. Every pediatrician loves to say this. You cannot take a little child and just give them the exact same treatment that you would give an adult with the same diagnosis. So their diseases manifest differently. We've seen that with what the lesions look like when they present. They're developing and growing, and we have to keep that in mind when we're giving them treatment. So the kids have robust immune systems, and by and large, they tolerate any sort of cancer-directed therapy much better than adults. But we have to think about the long-term implications. Every time I see a kid in my office, with every single visit, with every single treatment, I look at their growth curves and make sure that we're not disrupting their natural progression and pattern of development. They metabolize drugs differently. We dose drugs very, very differently in young babies compared to older children. They're dependent on others. They need their parents and caregivers to bring them in and bring them to attention. And that's sometimes a challenge in and of itself. They tolerate medications and treatments differently. And to emphasize a little bit about this, we have great therapies for melanoma now, and it's very easy to get an 18-year-old to take those treatments. But if it's a pill form and the pill can't be crushed, and it's a 2-year-old we're trying to give it to, that's not an option. If it's not in a suspension form or liquid form yet, the kid can't get that medication. The kids that we give injections to, it often takes two parents or two caregivers to hold them down for an entire year to give them therapy. And so this we have to keep in mind as we try to bring the great therapies we have for the adults to our pediatric population. And lastly, they just have a long life expectancy. When we're seeing a 3-year-old, we want them to live well into their adulthood, and we have to keep this in mind. So once we do have a diagnosis of melanoma, staging is no different than it is in adults. So we use the exact same staging system. Most patients, so 3/4 of them, will have localized disease at the time of diagnosis. However, children and adolescents often present with thicker tumors than adults or more advanced tumors by the T classification. This doesn't seem to necessarily impact outcome, but again, these are some of the questions that we have as to the why. And in the young kids, so when they're under 11, we see a much higher rate of positivity, meaning when we do the sentinel node, they have disease in their sentinel node, but they don't seem necessarily to have a worse outcome than their older counterparts. For prognosis, really many similarities with adult, and this is most dependent on stage. Even if a stage 3 pediatric patient seems to do better than an adult with stage 3, if you look at all pediatric patients, those with stage 3 and 4 disease do much worse than early stage disease. So 90% of our children and adolescents will be alive 5 years after their initial diagnosis. 60% of patients with node disease at presentation are long-term survivors. And again, just to emphasize, despite these thicker tumors and higher rate of positive sentinel nodes, their outcomes still seem to be better. We don't have a perfect study correlating the two, but if we look at numerous case series and case reports of pediatric melanoma patients, they just do better overall, and we're really not sure why, and that's an active area of research. Treatment for kids, we follow the same guidelines as we do for adults, but if you remember Dr. Holtzman's talk from this morning, he talked about how really we've gotten away from needing skin grafts with the more narrow margins. That's not always applicable in children, so a 2 centimeter margin on a 3-year-old's arm is significant, and so we do have children that still occasionally will need skin grafts to achieve the same margins on their much smaller bodies and surface areas. We do the sentinel nodes per the same adult guidelines, keeping in mind that with the spitzoid lesions, so not the true spitzoid melanomas, but the atypical spitzoid tumors, that we don't really know what to make of that. And we also heard earlier that we've gotten away from completion lymph node dissection for those patients that do have a positive node. But I should say we do still offer this in kids. You know, it's with some caution that we give those recommendations to kids because there were no kids in those studies whatsoever, and we don't know what the long-term implications are yet for our younger patients. And then adjuvant therapy. For years, kids were receiving interferon, and just recently we're starting to replace this with some of the immune checkpoint inhibitors and the targeted therapies. So while that's been going on for several years on the adult side, there's been not a single specific trial dedicated to pediatric patients in terms of adjuvant therapy and melanoma. And the dosing has been guided by adults, but it's very difficult whenever you have a small child. Just recently, we've been using some of these immune therapies in different cancers in kids who have advanced disease as a stage 1, as a early trial, and we're seeing that they are safe in children, and so we are offering those, specifically the checkpoint inhibitors. We need more pediatric trials here at Hillman, UPMC. We're starting to expand any of our adult trials that we have that can go down to the younger ages to be able to include them. And we will be opening soon a trial for advanced stage melanoma in children for some of the combination targeted therapies. So just a plug for our center. So you can find us on the website. We have a pediatric melanoma center. I see kids here at Hillman. I also most of the time spend my time up the street at the much more colorful building, and we're happy to see any kid that comes in and make sure that they're seeing the right provider, the right plastic surgeon, the right pediatric surgeon, pediatric dermatologist, and any of our adult colleagues who are happy to help with these patients as well. And just to close, this takes a village to support these families, make sure they have the right care, and we certainly need further research. And the future really is to improve recognition of these lesions, make sure we're improving the diagnosis, and really all of this is to improve our patients' outcomes. So with that, I thank you. Take any questions.